Okay. Thank you, Cecilia. Okay, so I'm here to, excuse me, we're going to go through the some case-based learning on cardiac assessment, specifically around, excuse me, heart sounds, and then also some case-based application to chest tube and pacing wire removal. So let me just go ahead and I'll start sharing my screen here.
So Carrie, if you click on the top one and with the little arrow and scroll all the way down to the bottom, you'll see your polls.
Okay. Great. Okay. Can you see my slides now, Cecilia?
I can see your slide.
Full slide? Okay.
Yeah.
All right. So we'll get started and then I'll launch the poll. So from what I understand, the best way, so I have nothing to disclose for this presentation. And I think the best way to do this is we'll go through each question and you can follow along, answer in the poll as we go through, and then we'll take up the correct responses at the end. Okay, so I'm going to launch the poll now, and you can follow along. Do you still see the poll there, Cecilia, now?
I'm not able to, but they probably are.
Okay, good.
They can let you know. Can you guys see it?
I can see it.
Okay, thank you. So, so our first question is: you're assessing a 6-year-old who does not have a history of heart disease. Which of the following is the best way to identify the point of maximum impulse? So we'll give you a couple, just a few seconds for your response. So is it using your stethoscope to auscultate where the pulse is heard the loudest, using your hand to palpate where you feel the pulse the strongest, or is it visually inspect the chest to identify where you see the pulse the strongest or the most active? Okay. This should say question 2. I'm not sure what happened there, but question 2. So you are assessing a 6-year-old who does not have a history of heart disease. Oh, what happened here? Something happened. Okay, not sure. We got that one question duplicated. Not sure what happened there. Sorry about that. Let me just make sure that I've got the right slides pulled up. And I don't. Okay. So just, sorry, can you just give me a second here? I'm going to stop sharing because I have the wrong presentation pulled up. My apologies. So sorry about this. Just give me a second. Yep, okay. Okay, I'm going to share screen again. Okay, sorry about that. Let's try this again. Okay, so we had our first question. Looks like nobody has answered yet. So hopefully you guys can follow along and answer. So our first question again is identifying the point of maximum impulse, either using your stethoscope, your hand to palpate, or visually inspect. Okay. The next question is, in a 6-year-old without heart disease, where would you most likely identify the point of maximum impulse? Is it the 4th intercostal space midclavicular, 5th intercostal space midclavicular? Is it the 4th intercostal space along the sternal border, or the 5th intercostal space along the sternal border? Are you there, Cecilia?
I'm here.
Okay, I don't see any voting, so I'm just wondering if people can
You
see
may
the
have
poll.
to can anyone see her poll? Otherwise, you may have to re-share your poll.
I think this is the same thing, Carrie, that we saw before. If we don't answer every single question, you can't see that we've done anything.
Yes,
Oh.
that's true.
Oh, I'm sorry. Okay.
Because we couldn't, yeah.
Thank you. Thank you for clarifying that. I didn't know that. Okay, I'll be reassured now. Okay, I can move forward. All right, next question. I'm new to this, obviously. Okay, so you identify that the child's point of maximum impulse is located at the child's 5th intercostal space and displaced laterally to the left. So you see here with the little heart, I put the heart here. So this is where you hear this is where you identify, sorry, the point of maximum impulse. Which of the following is most likely causing this? Mitral valve stenosis, dextrocardia, cardiac enlargement, or tricuspid valve regurgitation? So the point of maximum impulse in a child without heart, on a child 6 years old is displaced over here laterally. So 5th intercostal space, but it's more laterally to the left. Which most likely is causing it? Okay. Next question. You were auscultating an infant's heart sounds this time, and the patient, of course, is tachycardic. Which of the following most accurately describes the technique you could use to differentiate between S1 and S2? So this is a tool you can use that we went over earlier in the course. So is it this one? S1 is heard the loudest over the aortic and pulmonic valves, and S2 is heard the loudest over the tricuspid and the mitral valves? Or is it that S1 is heard loudest over the mitral and tricuspid valves, and S2 is heard the loudest over the aortic and pulmonic valves? I'll advance, just let me know if we're going too fast. So now we're going to play you a heart sound of a split S2 on inspiration. And the question is, which of the following is most accurate? So about a split on inspiration. Is this a normal finding because the pulmonary valve closes after the aortic valve? Is this an abnormal finding because the pulmonary valve closes after the aortic valve? this is a normal finding because the aortic valve closes after the pulmonic valve, or this is an abnormal finding because the aortic valve closes after the pulmonary valve. So let's have a listen.
Inspiration, expiration, inspiration, expiration.
So again, we heard a split S2 on inspiration. So which of the following would be most accurate to describe a split 2 on inspiration?
Inspiration,
Okay. Now we have another heart sound here for you. And this time it's not a tachycardic heart rate, it's slowed down to adult rates. So you can use rhythm to help you figure out, in this case, what type of murmur this is. Okay, so we're going to play you a heart sound. And which of the following best describes this type of murmur? Play it one more time. Okay. So our next question then, it's kind of, it dovetails on the last question. Which of the following would most likely cause this type of murmur? So the one you just heard, which of the following would most likely cause this type of murmur? Would it be aortic valve regurgitation, mitral valve regurgitation, pulmonary valve regurgitation, or tricuspid valve stenosis? Okay. So we have a new heart sound this time. So again, you can use rhythm to help you with this one because it's slowed down to adult rates. Listen to the following heart sound. Which of the following best describes this type of murmur? And then question 9, which of the following would most likely cause this type of murmur? Ventricular septal defect, a patent ductus arteriosus, an atrial septal defect, or mitral valve regurgitation? Okay. So this is our last heart sound. Again, listen to the following heart sound, and please, again, which of the following would best describe this type of murmur? course, the last question is, which of the following would most likely cause this type of murmur? Aortic valve stenosis, mitral valve regurgitation, pulmonary valve regurgitation, or tricuspid valve regurgitation? I can see the polling's being submitted now, so this is good. Now remember, it's anonymous, so there's no harm in guessing. And if there's any questions you'd like me to repeat, I'd be happy to do that. Considering that some of them are sounds, I'm happy to go back. Just let me know. All right, I think we're done. Okay, so let's have a look here and see. I'm going to go back to the first slide. Okay, so let's end the polling, and I'm going to share the results now. Okay, so hopefully everyone can see the results. So, so for the first question, assessing the point of maximum impulse. So technically, so it looks like 50%, the majority actually feels that it's using a stethoscope. Certainly, when you're listening to the apical pulse, using your stethoscope. Technically, for palpating the point of maximum impulse, it's when you're identifying the point of maximum impulse, it's technically palpating. So it's the correct response is using your hand where you feel the pulse the strongest. Okay. So in a 6-year-old, okay, so for a 6-year-old, looks like we're kind of split. The majority feels the fourth intercostal space. 33% feels the fifth intercostal space. Everybody, yes, is agrees it's along the mid-clavicular, absolutely. For younger babies less than a year, it's about the fourth intercostal space, and older children, it's the fifth intercostal space. So technically, the correct answer here was the fifth intercostal space, mid-clavicular. Okay. All right. So let's see our next one. So our next question was, you identify the child's point of maximum impulse was located in the fifth intercostal space and displaced laterally to the left, which should be, oh, so hands down, everybody, cardiac enlargement, absolutely the correct response. We see this quite a bit with our kids in severe heart failure, as well as dilated cardiomyopathy. Okay, great, well done. Question 4. You're auscultating the infant's heart sounds that are tachycardic, so you can't use the rhythm to help you identify which is the systolic and diastolic phase, which is really important. So the correct response here is S1 is heard the loudest over the mitral and tricuspid valves, and S2 loudest over the aortic and pulmonic. And so 75% of us got that correct, so well done. So that's a really neat tool that you can use to help you identify which is S1 and S2, and then subsequently be able to figure out which is your systolic and diastolic phase. And then from there, you can figure out which is your S3, S4, and any murmurs, whether systolic or diastolic murmurs. Very helpful in tachycardia. Okay, question 5. So question 5, we listened to the heart sound. It was a split on inspiration. So the correct response here is that it's a normal finding and the pulmonary valve closes after the aortic valve. That's great. 58% felt that the pulmonary valve closes after the aortic. 33% that just thought the reverse. Everybody knew it was a normal finding, which is great. But in fact, the pulmonary valve closes after the aortic, and that's because when a patient takes a breath in, you increase the stroke volume, the preload to the right ventricle. And because more blood is entering into the right ventricle, it takes longer for it to eject all the blood. And remember that the pulmonary valve will close after all the blood is ejected. So you see when a patient takes a breath in, there's more to the right, left to the left, less to the left side. And as a result, the aortic valve closes and the pulmonic valve closes shortly thereafter, creating a split sound, a normal split sound on inspiration. Okay. Okay, this time we listened to a heart sound, and let's see what people thought about this one. Oh boy, okay, yeah, so 75% got this one correct, that it was a systolic murmur. So this one here, I'll just play real quick. So you can hear, if you imagine the lub dub with this question, lub dub, you can hear that the murmur starts at the lub because we have the rhythm, benefit of the rhythm. So this is a systolic murmur. Okay. And let's see what you said about what would cause this murmur. Oh, so 58% of you got this one correct with mitral valve regurgitation. So absolutely. So during systole, when the ventricles are contracting, particularly that strong left ventricle is contracting, if you have mitral valve regurgitation, you will have shunting and a subsequent murmur during systole. So let's think about the other options. Aortic valve regurgitation. Well, no, because aortic valve regurgitation would occur during diastole. So that would be a diastolic murmur. Pulmonary valve regurgitation, same thing as aortic valve, and that pulmonary valve closes during diastole. So if you have regurgitation, it would be a diastolic murmur. A tricuspid valve stenosis does cause a murmur, but again would cause a murmur during diastole when the atria contract towards the end of diastole. Okay, so good job on that one. Oops. Okay, so the next question was question 8. Oh yes, so 75% of you definitely feel that this is a continuous murmur. So it was quite a loud murmur so you could hear the murmur through all phases of systole and diastole. So let's see what you said for would most likely cause it. So 83%. This is like you have to get the last question right to get this one right. But yes, so the most likely cause of this type of murmur would be patent ductus arteriosus. Okay, so we listened, this was our last heart sound. Let's hear what you guys thought here. So question 9. Nope, sorry, question. Oh, I got my numbers mixed up, I think here. Let's see. Oh yeah, I've got 9 written twice. Sorry about this. Is actually question 10. Question 10, which of the following would most likely cause, no, sorry, my bad. I think my questions are mixed up a little bit, but anyways,
we had a poll option for this one.
Okay, I'm so sorry. I think I messed up. Okay, so let's just go over this one. So this one, you probably know. So thanks for your patience, everyone. So what kind of murmur, let's just do a call out. What kind of murmur is that one, do you think? I can play it again.
Diastolic.
Yeah, so that's a diastolic murmur. So then we can go to the next question. So you can hear the murmur starts at the dub, right? Lub dub, and you hear it start after the dub. Okay, so our last question, which of the following would most likely cause this type of murmur, a diastolic murmur? Let's see what you said. You said pulmonary valve regurgitation, 75%. You are absolutely correct there. That 75% of you, that a pulmonary valve regurgitation, because pulmonary valve regurgitation happens during diastole. So we can actually rule out all the other options based on the fact that they wouldn't cause murmurs during diastole. Let's think about it. Aortic valve stenosis. So that, yes, aortic valve stenosis would cause a murmur, but would cause it during systole when the ventricles are contracting as the blood was trying to get through the stenotic valve. Okay, pulmonary valve regurgitation. Pulmonary valve regurgitation is the correct answer. So the next one, mitral valve regurgitation. So mitral valve regurgitation would be a systolic murmur. So when the ventricles were contracting, blood would eject into through the mitral valve, regurgitate into the atria, causing a systolic murmur. Tricuspid valve regurgitation would also be during systole. When the right ventricle was pumping, blood would back up, regurgitate into the right atria during systole. All right, so you guys did great. So just stop sharing that for a second, or stop sharing. And we'll just move, because we're going to go right into your next runner-up as well for chest tubes and pacing wire removal. Okay. Share again. Okay. Let's pull up the board. Okay. So this one is a short poll. Hopefully, Cecilia, are you seeing my slides again for chest tube and pacing wire removal?
Yes.
Thank you. Okay. Okay, so we're going to do the same process we did last time. I've just launched the poll, and we're going to go. We just have a few questions here, nothing to disclose. Okay, our first question. This is pertaining to pacing wires. Which of the following is considered the safest timing for removal of pacing wires? So for patients on a heparin infusion, after holding for 1 hour. Option 2, for patients on low molecular weight heparin at the trough. Patients on warfarin within 2 days of initiation of therapy or when INR is less than 2.5. Okay, next question. Which of the following personal protective equipment is recommended for the removal of pacing wires and chest tubes? Gloves, first option, gloves and gowns. Gloves, gowns, procedural face mask. Gloves, gowns, procedural face mask, and eye protection. Okay. this is one of the, I think, can be one of the daunting things about removing chest wires. So we thought we would add this to our poll. Which of the, oh, nope, this is not. Okay, so this question should be, I think it's just, yeah, I copied it incorrectly. Okay, so in your poll, it's written correctly. It should say, number 3, which is the safest spot to cut the pacing wire in this photo? Okay, so for your poll, in your question, if you look at this photo, is it spot A right here, B right here, or C? Which is the safest spot to cut your pacing wire? Okay. Following pacing wire removal, bed rest and continuous electronic cardiac monitoring is recommended for which of the following reasons? Tamponade detection, pain management, or arrhythmia prevention? You probably knew this question was going to be on here. Before removing this chest tube, which of the 2 sutures shown here should be cut? Should it be this one here, A, or should it be this one right here, B? Also, another stressful thing when you're removing chest tubes is cutting the appropriate suture. And then when removing a chest tube, which of the following would be most effective in preventing a pneumothorax during tube removal? Apply pressure above the tube. Ask the patient to take a big breath in and hold it. Apply pressure above the tube. Ask the patient to exhale fully and hold it. Apply pressure below the tube and ask the patient to take a big breath in and hold it. Apply pressure below the tube and ask the patient to fully exhale and hold it. Okay, it looks like everyone is finished, so I'll just back it up. Oh, some people are changing their minds, but that's okay. Okay, I think we're done. I think. Oh, no, we're not quite done. I'll let you guys, looks like we're about 52% voted. I'll just give you one more minute. Okay, we're not having any increases here, so I think we'll just take it up. Okay, so I'm going to end the polling and I'm going to share the results. Okay, so for question 1, which of the following is considered the safest timing for removal of pacing wires? It's really the process of elimination here. Low molecular heparin, patients on low molecular heparin such as enoxaparin at the trough. So when the medication's at its lowest. Now, the other 2 could be eliminated. Heparin if they're on a standard heparin infusion, generally you need to wait at least 2 hours, ideally 2 to 4 hours before removal. And typically, it's recommended to pull the wires before a patient starts on warfarin. And if they, or at least when the INR is less than 1.5. Okay. So we were almost 44%. We were split between us, mainly between the heparin infusion and low molecular heparin at the trough. Okay. So the next question is the PPE. And 89%, good for us. We're out to protect ourselves, so that's good. So this is just a really good reminder. With chest tube and pacing wire removal, splashing is very, very possible and very common. So it's really important to protect yourself, particularly, wearing all this PPE. So the correct response is gloves, gowns, procedural face mask, and eye protection, because splashes are imminent. This question was a little bit misworded here, but basically this question is the safest spot for cutting the wires. So let's see what people thought. Was it A, B, or C? So 56% of you said C, and that is the correct answer. So this is the one, this is the wire that goes down and goes to the pacing wires that then connects to the external pacing wire box. If you weren't sure, we would clean the area very well and just kind of pull the knot slightly to make sure that this is the part that's pulling, going to be able to be pulled through. So then this part would be pulling from the patient, from inside the patient. And the key too is to always cut a little bit extra, just in case you did cut the wrong portion, so that you could still remove it if you did cut the wrong one. Okay. So 56% said C, correct answer. Following pacing wire removal, bed rest, and electronic monitoring is recommended for which of the following reasons mainly? Yes, so 67% said tamponade detection, and that is correct. Patients may have an arrhythmia, but we put them on for arrhythmia, like to look for it, not really to prevent it. Pain management, it's not really significant. We don't really find that it's really painful after the wires come out. So it's really, we want to see those early signs of tamponade. Yes, there may also have arrhythmias, and we will be watching for that. But the main reason for these three options here is to look for signs of tamponade, which would, of course, would be tachycardia or sinus tachycardia. Okay, before removing this chest tube, which of the sutures here should be cut? So let's have a look. You guys said 78% B. That is correct. It can be very challenging sometimes to differentiate between the purse suture and the retention suture. So sometimes, you've got to really get up close and personal and make sure that you're cutting the correct suture. And that's this one right there. That's basically, it's looped through the skin and connected to the tube. That's the one that keeps the tube in place. Okay. And 78% got that. Perfect. When removing a chest tube, which of the following would be most effective in preventing a pneumothorax? Great. So 67% said apply pressure above the tube. So you have your second person applying some pressure above the tube to close the tract, to apply pressure and close the tract to prevent air from getting sucked in. And it's recommended that the patient bear down. So take a big breath in and hold it. If it's a baby that's crying, then wait until they fully inhaled and they're just started crying, then take it out then. So that there is some literature to support bearing down at the end, at the beginning of exhalation, at the end of inspiration, to remove tubes to prevent pneumothorax. Okay. Any questions or comments about this applied application or application kind of learning?
Thank you, Carrie.
You're welcome.
All right. So we have one more very quick OSCE on defibrillation cardioversion. I don't know if people want to take like I'm sorry, I didn't give you a break actually in between. But if we can end early, but if you want to take 5 minutes and just go to the washroom, stretch for a few minutes, and then we can do the last one. How does that sound?
Sounds good.
Sounds good. Okay, let's take 5 minutes. I'll get set up and then we'll have an early weekend. So Carrie?
Yep.
Can you make me host again if I'm not host?
Oh, yes. Okay. All right. Sorry.
And I think you're still sharing your screen.
Yeah. Oh, am I? Okay. Sorry.
There we
Jeez,
go.
I'm such a rookie. Okay. Okay. So how do I?
Okay, if you go find to participants and find my name,
Mhm.
and then you can, the more button, you can make me the host.
Okay. And are we still? Oh, we're still recording. Okay.
Well, I'll stop this and start a fresh one.